Thank you very much. So today I'm going to talk on the second part of this CME. My earlier speaker, Dr. Mukherjee, has very well said the context of depression and the menace of depression, the burden of depression in the global context. So now I'm going to shed lights on its mechanisms, pathophysiology, and diagnostic criteria with a case discussion. So as all we know, the basic understanding of depression actually came from this monoamine hypothesis, that the deficiency or imbalance in the monoamine neurotransmitters like serotonin, dopamine, norepinephrine in the synaptic cleft was primarily thought to be the main mechanism of depression. And now the statement is generally aimed at counteracting these low or abnormal monoamine activities and increasing at least one of these three key neurotransmitters. Those are still thought to be associated with depressive disorder or depression. So if I talk about the pathophysiology of depression, there have been tremendous changes in the concept of the pathophysiology of the depression. So as previously we thought that these monoamines were primarily associated with depression, but one of the fact that very important antidepressant, tianeptine, when this tianeptine came into existence, that the entire climate of thought had a paradigm shift. So what it is was seen is that this tianeptine was a serotonin depleter, and yet it had antidepressive action, and like that way the concept of neuronal plasticity came into existence, that the error in or impairment in neurogenesis in the it leads to the volume loss in the hippocampus and atrophy, and that is there is a program. Apoptosis is the programmed cell death, and neurogenesis is the generation of the new neurons. So what it is seen is that, as we previously thought, that nerve cells once dead cannot regenerate, but this neuronal plasticity it tells us that it's a neurogenesis and apoptosis. It's a continuous process, and in depressive disorder it makes a chaotic situation where the loss of neurons, apoptosis, is overweight the neurogenesis. Then simultaneously other concepts like neuronal inflammation, where the increased interleukin, T-necrotic factor and C-reactive protein, etc., these also came into the picture, that these are also associated with depressive disorder. Simultaneously, apart from this neurotransmitter imbalance, this serotonin, norepinephrine and dopamine, this brain-derived neurotropic factor is also found to be very strongly associated with depression. So what happens in depression? There is some error in the signaling inside the cell, inside the cell, that leads to the production of BDNF. That is, BDNF is the trophic factor. It causes the neurons to have newer offshoots and newer connections, and ultimately increasing the hardware of the brain, and it's ultimately increasing the RAM of the brain. And simultaneously, apart from all these mechanisms, this synaptic dysregulation is also thought to be very strongly associated with depressive disorder. if I talk about this synaptic dysregulation, then the concept of NMDA receptor dysregulation would come into the picture, where there is gradual calcium seeping inside the cell. When neurons goes into hyperexcitability, so there is the seeping of calcium inside the cell, causing the vesicles containing the lytic enzymes to be dissolved, and ultimately the autolysis or death of the neurons. Apart from that, the dysregulation of GSK, that is the glycogen synthetase kinase. Basically, it is associated with diabetes glycogen metabolism, and it is also found to be associated with cell signaling, then cellular transport, and nowadays usually this the concept of mTOR, that is the mammalian target of rapamycin, and it is also found to be associated with depression. Basically, these mTORs are the future drugs, future longevity drug, and it is found to improve the immune function, and it reduces the stress responses, and it also reduces this autophagy or apoptosis or autolysis of the neurons. So the concept of the depression has seen so many paradigm shift, and newer concepts are still coming up, and it has paved the way that so many possibilities of very unique form of future drugs in the near future. In the pathogenesis of the depression, the stress is a risk factor for development of depression. So stress leads to decrease in the brain-derived neurotrophic factor that I was talking about, and it causes disinhibition of the hypothalamic pituitary adrenal axis. That is the very older find and older concept, and depletion of the monoamine neurotransmitters. So neurodegeneration and the reduced hippocampal volume is one of the most important mechanism of depression, and this is also clearly reproducible. We can measure the hippocampal volume, and we can see the changes in the hippocampus in depressed individual, and we can also see the changes after antidepressant therapy, regardless of pharmacotherapy or cognitive behavioral therapy, and these have become so robust and reproducible with functional MRI or PET scan or SPECT scan, and it has validated the concept of depression. And reduced this hippocampal volume is the key biological feature of depression, and therefore it is the future potential target for treatment of depression. So as you know, the diagnostic criteria of the depression, as per DSM-4, these 5 or more symptoms over at least 2 weeks of time, and among all those 5 symptoms, there might be at least one symptom should be depressed mood or anhedonia or loss of interest in previously pleasurable activities, and 4 or more of these symptoms could be changes in appetite, weight loss or weight gain that is unrelated to dieting, trouble sleeping or sleeping too much, loss of energy, increased fatigue, increase in purposeless physical activity or slow movement or speech, feeling worthless or the feeling of guilt, difficulty in concentrating and thinking, suicidal thoughts, feeling hopeless, helpless, worthless, and these symptoms causes clinically significant distress or impairment in social and occupational functioning or other areas of functioning, and this episode is not attributable to the physiological effects of any substance or any other medical conditions. And so the criteria A to C represents the major depressive disorder. And the occurrence of major depressive episode is not better explained by schizoaffective disorder, schizophrenic disorder, delusional disorder, or other specified or unspecified schizophrenia spectrum, or other psychotic disorders. And there has never been a manic episode or a hypomanic episode too. So as for ICD-10, this depressed mood as reported by individual as feeling low, feeling down, sad, or as observed to be tearful, defeated appearance, and in children and adolescents, depressed mood can manifest as irritability and markedly diminished interest or pleasure in activities, especially those normally found to be enjoyable by the individual earlier. And presence of either of the two is a must, that is the reduced ability to concentrate or sustain attention or task, or marked indecisiveness. So in considering ICD-11 diagnostic criteria, the beliefs of low self-worth or excessive or inappropriate guilt that might be manifestly delusional, recurrent thoughts of death, recurrent suicidal ideation, evidence of attempted suicide, and substantially disrupted sleep or excessive sleep, substantial changes in appetite or weight, psychomotor agitation or retardation, reduced energy, fatigue, or more tiredness following the expenditure or only a minimum effort. I'm coming up with a very small case presentation. So it was a 29-year-old lady with a history of one episode of depression 2 years back, and was brought to psychiatry consultation with complaints of sadness of mood, anxiety, hopeless, helpless, suicidal ideation, and disturbed sleep for last 20 days. And she had delivered a male child 25 days prior to psychiatric consultation, and it was an elective cesarean section. And she also had a recurrent thought to kill her baby, and which was quite distressing for her. And there were no any compulsive acts against that. So she was repeatedly asking to keep her baby safe from her. In the last 2 weeks, her self-care has declined significantly. There was first pregnancy of the patient. It was the first pregnancy, and she had regular antenatal follow-ups, but no psychiatric treatment record could be found or any history of psychiatric consultation, and had received iron folic acid as well as calcium supplementation during the antenatal period, and got all the vaccines. And there was no family history of psychiatric illness, and there was no psychosocial stressors. So treatment was managed, planned with escitalopram for depression and anxiety, and also it was thought to take care of all those obsessive symptoms. And for her anxiety and for the transient relief of anxiety and normalization of the sleep, benzodiazepines were added. Thank you very much. I'm stopping to share, and I pass on to the organizers for the next topic.
Thank you, Dr. Rezaul, Hamid sir, for such a nice elaboration on the diagnosis of depression. And thank you, Dr. Ali Mukherjee sir, as always, for giving a very brief and lucid introduction to the subject.